Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. During my last shift on our ICU, I saw a couple of patients admitted to us after cardiac arrest, so I got an idea to make a video about post-cardiac arrest care. Cardiac arrest could occur out of hospital as pre-hospital or during hospital admission as inpatient. Here, in this video, I'd like to focus more on out-of-hospital cardiac arrest and discuss how to manage comatose survivors of cardiac arrest who require mechanical ventilation and other major organ support on intensive care unit. During out-of-hospital cardiac arrest, paramedics will resuscitate the patient on their way to hospital A&E, and if the patient survives and has return of spontaneous circulation, admission to ICU will be the next step if the patient is still in need of organ support and neuroprognostication. The survival of the patient mainly depends on the duration of cardiac arrest, which is no flow and low flow period, leading to initial hypoxic ischemic insults to the brain and heart, and also on the subsequent reperfusion injury after ROSC, as well as any background comorbidities. A lot of post-cardiac arrest patients will require multiple organ support, and about 50 to 60% of these patients will eventually die. To enhance the possibility of patients with cardiac arrest to survive, we need to follow the steps called change of survival. It is vital to recognize cardiac arrest and call for help early. Patients who have witnessed out-of-hospital cardiac arrest have 2.5 times greater chance of survival to hospital discharge compared with unwitnessed out-of-hospital cardiac arrest. Early bystander cardiopulmonary resuscitation has been shown to raise the chance of survival by twofold. Early, minimally interrupted resuscitation and defibrillation in those with shockable rhythms after cardiac arrest is the key to improve survival. Early advanced life support with standardized post-resuscitation care is the last crucial bit of change of survival. Cardiac arrest patients will need proper initial management and stabilization by pre-hospital medical team before transfer to hospital emergency department. Patients may require airway support either with trachea tube or supraglottic airway like IGEL. Assisted ventilation is usually required during pre-hospital care, with self-inflating bag more commonly used than mechanical ventilation. Mechanical chest compression devices, Lucas device for example, can be used in patients who require ongoing CPR or prolonged CPR in transit, such as those with refractory dysrhythmias and suspected acute coronary syndrome, requiring longer transfer to a tertiary specialist cardiac center. The most commonly used drugs for CPR are adrenaline and amiodarone. Time to return to spontaneous circulation is defined as the time from a witnessed collapse or emergency telephone call for an unwitnessed out-of-hospital cardiac arrest to sustained ROSC. That may include both a no-flow period if there is any delay in starting CPR and a low-flow period between the commencement of CPR and sustained ROSC. Increasing time to return of spontaneous circulation is associated with poorer neurological outcomes. Patients who achieve ROSC before transfer and are transported to hospital with ROSC have higher survival to hospital discharge rate than those who achieve ROSC in transit or who are transported to emergency department in cardiac arrest state. We can transport patients with cardiac arrest to emergency department of the nearest hospital or to tertiary cardiac center if the cardiac cause of cardiac arrest is strongly suspected via land ambulance or air ambulance depending on the location. After hospital admission, care must be focused on the identification and treatment of the cause of cardiac arrest, and the assessment and mitigation of ischemia-related reperfusion injury to multi-organs, mainly brain and heart. Patients who remain comatose following ROSC or who have another clinical indication for sedation and mechanical ventilation should have trachea intubation in the emergency department if it's not been done already during CPR. Patients who have had a brief period of cardiac arrest followed by an immediate return of normal cerebral function and normal breathing may not require trachea intubation, but should be given oxygen via a face mask. Target SpO2 range is 94 to 98% unless chronic type 2 respiratory failure. We should aim for PaO2 10 to 13 kPa and PaCO2 4.5 to 6 kPa. Accurate titration of FiO2 should be based on ABG measurement. We should use the lung protective ventilation strategy, aiming for a tidal volume of 6 to 8 ml per kilo's ideal body weight. Following cardiac arrest, a period of hemodynamic instability resulting in low blood pressure commonly occurs. Guidelines recommend to keep systolic blood pressure of at least 100 mm mercury and mean arterial pressure above 65 mm mercury. Organ perfusion should be maintained with fluids and noradrenaline or adrenaline, and if needed, dobutamine, depending on individuals' need for intravascular volume, vasoconstriction, or inotropy. Replace electrolytes to avoid electrolyte derangement, mainly hypokalemia. In advanced specialty centers, mechanical circulatory support, intra-aortic balloon pump, for example, could be considered for persistent cardiogenic shock from left ventricular failure. In patients with acute coronary syndrome and recurrent VT or VF, left ventricular assist devices or arteriovenous extracorporeal membrane oxygenation could be taken into consideration. Seizures, if present, should be controlled with levetiracetam and sodium valproate, which are suggested as first-line anti-epileptic drugs in addition to sedatives, as seizures could increase cerebral metabolism and worsen the pre-existing hypoxic brain injury. Routine seizure prophylaxis, however, is not recommended. Targeted temperature measurement around 36 degrees Celsius is recommended in adults who remain unresponsive after ROSC. I will discuss the details in a minute. We should also check the blood glucose to ensure the patient is not hypo or hyperglycemic. After stabilizing the patient in ED, we will need to promptly commence the urgent initial investigations such as 12-lead ECG, coronary angiography, CT HAT, and CT pulmonary angiogram before transferring patients to intensive care unit. Focused transthoracic echocardiogram could be helpful for bedside diagnosis to quickly assess, for example, regional wall motion abnormality for acute coronary syndrome, right ventricular function for massive pulmonary embolism, or pericardial effusion for cardiac tamponade. For the majority of patients with out-of-hospital cardiac arrest, the primary cause of the arrest is cardiac abnormality, especially if they are at high risk of cardiac disease. When such patients have ST elevation on their post-cardiac arrest 12-lead ECG, they should be referred urgently to cath lab and interventional cardiologists for consideration of immediate coronary angiography and percutaneous coronary intervention without any delay. Those who do not have ST elevation on ECG, however, are hemodynamically unstable and considered to have a likely cardiac cause for cardiac arrest, should also be referred urgently to cardiologists for potential urgent coronary angiography. Patients who are presented with life-threatening arrhythmia or underlying cardiac disease cardiomyopathy, for instance, can benefit from ICD insertion. The timing of discussion with cardiologists is important as early intervention has the potential to improve the outcome. If clear cardiac cause of cardiac arrest is unlikely, early CT HEAD and CTPA could be useful for the diagnosis of the cause of cardiac arrest, for showing evidence of hypoxic ischemic brain injury like loss of gray white differentiation and or suckle effacement, which is one of the features of poor prognosis, and for the identification of complications of CPR such as rib fractures, hemo or pneumothoraces. Among post-cardiac arrest patients following ROSC, a minority of patients regain consciousness immediately. The majority remain either unconscious or confused. Therefore, after cardiac intervention or imaging, admission to ICU is necessary for airway protection, additional organ support, neuroprotective measures, and to allow more formal neurological assessment. On intensive care unit, we will keep the patients intubated and continue respiratory support by positive pressure ventilation. Hypoxemia is potentially harmful, particularly in patients who are already with hypoxic ischemic brain injury. Persistent hyperoxemia in the first 24 hours post-cardiac arrest might be associated with increased mortality as it could cause cerebral vasoconstriction. Moreover, hypocapnia may worsen brain ischemia, and also hypercapnia could lead to cerebral edema and increased ICP, so both conditions should be avoided. Hence, we should aim to achieve SATS target 94 to 90%, PO2 10 to 13 kPa, PaCO2 4.5 to 6 kPa, and tidal volume of 6 to 8 ml per kilos ideal body weight as mentioned above. When prolonged respiratory support is required or slow neurological improvement is anticipated, tracheostomy can be used to facilitate weaning mechanical ventilation without sedation need. The optimum mean arterial pressure is likely to be different in every patient. MAP should be maintained at least 65 mm mercury, ideally 70 to 90 mm mercury, to achieve adequate urine output 0.5 ml per kilo per hour and normal or decreasing plasma-lactate value. Here, we need to balance between maintaining sufficiently high MAP to ensure cerebral perfusion and minimizing cardiac work, especially in patients with potentially poor myocardial function. It is required to do neuro observation, which includes hourly GCS and pupil assessment. On our ICU, we use automated pupillometer to assess pupil size and reactions accurately. If you would like to know more about pupillometer, please let me know in the comment section and I'll make a separate video about it. Post-cardiac arrest patients are generally sedated for at least 24 hours prior to the first sedation hold. Where there is any doubt about neurological function on admission, we should use short-acting sedatives and opioids, for instance, propofol and remifentanil, to facilitate the delivery of organ support and to implement neuroprotective measures. Persistently low GCS in the absence of sedation during sedation hold can be due to hypoxic brain injury or seizures. Seizures could be presented as clinical status epilepticus, subclinical or non-convulsive status epilepticus, or myoclonus. Anti-epileptic drugs which can be used to control seizures on ICU are propofol, as well as first-line AEDs like levetiracetam and phenytoin or sodium valproate according to local hospital guidelines. Although status epilepticus and myoclonic status are associated with advanced outcome, they have been reported to be present in survivors with good neurological outcome. Fever commonly occurs in first 48 hours after cardiac arrest, and it is associated with poorer outcome. Therefore, temperature more than 37.5 degrees Celsius should be avoided for the first 72 hours or until patients awaken. Targeted temperature management is indicated in comatose patients who are ventilated on ICU following ROSC. We used to maintain patients' temperature between 32 and 36 degrees Celsius. However, recent studies and evidence suggest that there is no benefit from using hypothermic temperature control. Approach to targeted temperature management includes simple measures such as exposure of the patients, paracetamol, and active cooling with external cooling device, for example, ice packs, cooling blankets, and intravascular device like IC temperature control catheter, what we call CoolGuard on our unit. The CoolGuard could also be quite useful as central venous access since they can provide multiple lumens for IV drug and fluid infusions. Specific nursing care is essential to look after the CoolGuard and the temperature control device attached to it. Patients will need to be under sedation, and continuous on-screen ECG monitoring is also necessary. Occasional 12-lead ECG should be done if significant arrhythmias occur. The CoolGuard catheter should be removed when temperature control has been completed after 72 hours, or if the patients become awake, whichever is earlier, as there is risk of venous thrombosis in femoral vein if the catheter is left there for a longer period of time. Electrolytes need to be replaced if they are out of range. Fluid balance should be monitored on chart and aim to be neutral. Enteral feeding can be started soon after ICU admission. Stress ulcer prophylaxis with PPI should also be considered. Target blood glucose level should be between 8 and 10 mmol per liter as a neuroprotective measure. Insulin infusion can be started if required. At all costs, we need to avoid hypoglycemia, which is BM less than 4 mmol per liter. DVT prophylaxis is important in comatose ICU patients. HB should be monitored and kept between 80 and 100 grams per liter, especially in post-cardiac arrest patients with underlying ischemic heart disease. The major cause of death in patients with ROSC after cardiac arrest is brain injury. 2/3 of patients die due to perceived neurological injury after being admitted to ICU. Prognostication is crucial to identify individuals with potential for survival as accurately as possible to avoid inappropriate withdrawal of life-sustaining treatment. Likewise, reliable prediction of poor outcome will facilitate discussions with relatives and will help to inform any decision to withdraw life-sustaining treatment. European guidelines on prognostication, which we use in the UK, highlight the importance of giving sufficient time for the brain to recover. Therefore, prognostication should be started after at least 72 hours from ROSC. And if patient is still comatose with Glasgow Motor Score of less than or equal to 3, after sufficient time has been given to clear off all sedatives and neuromuscular blocking drugs. Since no single neuroprognostication predictor is 100% accurate, they also recommend using multimodal neuroprognostication strategy to test for the severity of hypoxic ischemic brain injury and likelihood of a good recovery, which means whether the patient could return to independence. Now, I'd like to talk about 4 methods of prognostic testing. Clinical examination should be done daily after sedation hold to assess seizure activities, motor response of pressure stimuli, pupillary and corneal reflexes. We need to make sure patients' vitals such as blood pressure, heart rate, temperature, and BM are normal and also free from electrolyte and metabolic derangements to assess neurology properly. We should request EEG at 72 hours or earlier if any suspicion of seizures. Somatosensory evoked potentials should be considered at 72 hours if definitive information could not be obtained from other prognostic tests. We can also put on Bispectrum Index, BIS, but it is not as reliable as standard EEG. Imaging, like CT, are usually done before ICU admission. If it is not done for some reason, it can be done at 72 hours. Repeating the CT head may be helpful because CT evidence of hypoxic ischemic brain injury evolves over the first few days. We can consider MRI head if CT scan is not conclusive. Biomarkers such as neuron-specific analysis (NSE) should be monitored at 24, 48, and 72 hours. The trend of NSE is more significant than a single value. The predictors to be considered as prognostication are status myoclonus within 72 hours, no pupillary and corneal reflexes after 72 hours, highly malignant EEG after 24 hours showing suppressed background with periodic discharges or bus suppression, bilaterally absent N20 SSEP waves after 24 hours, diffuse and extensive hypoxic injury on CT or MRI head. NSE after 40 hours is more than 60 microgram per liter or increasing NSE values after 72 hours. When two or more of these predictors are present, the patients are likely to have poor outcome. Of course, most of these signs can be recorded before 72 hours from ROSC. However, their results will be evaluated only at the time of clinical prognostic assessment. If any of these tests are indicating a potentially good outcome, then any decision to withdraw life-sustaining treatment should be made very cautiously. If there is any doubt, we should re-evaluate in 24 to 40 hours. After confirming the poor neurological prognosis, it is time to think about withdrawal of life-sustaining therapy. Withdrawal consideration should also be made according to age, comorbidities, general organ function, and patient's preferences. We should invest plenty of time in communication within the team and also with the relatives. In appropriate patients, family conversation regarding organ donation should be approached by specialist nurses together with ICU team. All decisions concerning organ donation must follow local legal and ethical requirements. It is a very broad topic, so I will discuss it in another video. Survivors of cardiac arrest require a tailored package of follow-up care which consists of neurological, cardiac, and physical rehabilitations. We should organize follow-up within 3 months after hospital discharge, including screening for cognitive problems, emotional problems, and fatigue, and also providing information and support for survivors and family members. I'll stop this video here. It's been quite lengthy already. Thank you for coming this far. Hope you learned something new in this video. If you do, please share with your friends and colleagues. I'll see you in the next video. Take care.